I'm Susan Acott and I'm the Chief Executive here at East Kent Hospitals Trust. And today I'm with some colleagues and we wanted to have a little bit of a talk around haemato-oncology and what goes on in that service. However, firstly, if I can get my colleagues to introduce themselves. Moya, starting with you.
Yeah, so I'm Dr. Moya Young and I'm one of the haematology consultants here on clinical lead.
My name's Webster and I'm the ward manager for Brabourne ward, which is the haematology unit.
I'm Steph Goodchild and I'm the lead clinical nurse specialist.
Okay, Stephanie, so if I could ask you to explain to me in terms that I would understand as a non-clinician what haemato-oncology is?
So haemato-oncology is cancers of the blood and bone marrow, and that includes the leukemias, lymphomas, myelomas. Some of these diseases are chronic, some of them are acute, and they're all treated in very different ways.
So really what I wanted to talk about today was why the haemato-oncology service in East Kent is quite so special, particularly from the point of view of research. But I don't think we can probably start talking about that before just reflecting on what you've been doing during this time of COVID and how you've, how it's been different for your service and your patients during this time. So how have you fared, Moya?
Well, I think it's all been challenges, as there has been for every team. We've always had a background of some telephone consultations with a lot of our chronic, stable patients, so we were able to adapt quite quickly, and the admin staff did a fantastic job in turning that around very quickly. And the majority of our patients now are all done on telephone clinics, and for our new cases we get them in specifically at certain time spots. There's only one person arriving to the department at any one time, and we have all the changes and adaptations to the clinical waiting room that we've put in place to keep it safe. And we've been able to discuss these new cases with them face to face and do the consenting process that way. For some patients perhaps who have already been through that process of consenting and have had diagnosis and perhaps it's come back, we've been able to do some of the consenting over the phone and email the information and keep them up to date that way.
Have you been able to do this on a multidisciplinary basis in terms of how's that been for you on a multidisciplinary basis?
I mean, Steph, she's been doing a sterling job.
I have been, so my job has changed completely because it's all on the telephone now.
Okay.
And one of the things we do is patient-initiated follow-up. So patients that have completed their treatment, we ask them to phone in if they get any signs and symptoms that are worrying, rather than wait for a 6-month or a year appointment. And it's quite challenging to get somebody to describe what their neck lump or their groin lump or their rash looks like. But hopefully going forward we're going to be able to include video conferencing. But so that's been a challenge, but I think we've done pretty well actually.
Just from the point of view of the patients, I can see some advantages to not having to come to the hospital, but equally I can see some real issues. How's your sense that the patients have experienced that way of doing things?
I think a lot of our patients are very frightened, and so they're actually relieved that they don't have to come to the hospital. They're relieved that they're not putting themselves at that unknown risk, but that they've still got a familiar voice at the end of the phone. It's still their same old CNS, I'm still there. A lot of my patients I telephone anyway, so in that way I've just sort of expanded that part of the service. But I think the patients are actually relieved that they're still getting a service, but it's adapted to their current needs.
Continuity, but not as you know it.
Yeah.
And what about you, Jess?
I think we faced some massive challenges. Our patients have to come into hospital for their treatment. There's no way around it. Meeting patients for the first time with a new diagnosis, you feel for the patients anyway. In the best of times, they're incredibly frightened. To walk onto a ward during a pandemic and to meet a nurse for the first time in apron, gloves, mask, it must be terrifying. Also, because of the pandemic, we're not allowed to have visitors on the ward. So a lot of our patients, particularly those with AML, are not allowed, they're in for a month. So to not have visitors in for a month with them, have to sort of open up to strangers, although we very quickly form relationships with our patients, bearing in mind what we all go through. It's been incredibly challenging. And
so you're having to supplement the family role
very,
for those,
very much, very much, and also supporting the
well.
family on the end of the phone, because they're terrified for their loved ones and they can't see them. They're speaking to them on the phone. We've got some iPads, so we're able to do some FaceTiming. Thank goodness for technology. However, when they're feeling too sick, we have to speak to families a lot more on the phone than we ever did, rather than face to face.
So I'm really interested. I know we probably should be talking about your research, but I'm quite interested about. So we've got to live with COVID for another year or two maybe in terms of the ups and downs of it. So how are you going to go about kind of refining this approach? Because it sounds like you're going to have to stick with this approach to some extent.
Absolutely. I mean, we had a perfect storm. As the shutdown occurred, we got 10 new acute leukemias kind of occur over a couple of weeks. We hadn't had that volume for a long time, and we had to rapidly adapt and change. And the Brabourne team are fantastic. They've always been a hands-on support network for all our patients, but it's just really strengthened that. And I think we've also had to look at how we manage all of our patients. So far, I think I can't think of anybody we haven't treated. We may be adapting our approach with how we are treating them. NICE and NHS England have brought in a whole new raft of treatments sooner that we've been able to get access to, which have less immunosuppressive effects on them. The pharmacy team have done so much work in trying to get these things through very quickly. They've been absolutely amazing. And so we're looking at how we are managing patients. Like a lot of our low-grade lymphomas, would give them maintenance treatment after they've had their induction chemotherapy. We know that improves their progression-free survival, but doesn't improve their overall survival and puts them at much higher risk of infection. So we've stopped giving the maintenance treatments and just gone to back to period of observation. We changed perhaps for less intensive chemotherapies where there is less immune suppression, but still a good chance of getting into remission. So this is something that we're changing with week by week, but so far
I have to
we've been able to provide a service to all our patients.
It really sounds super complicated, and particularly with all the aspects of, for example, the pharmacy and all those different aspects of it. But at the end of the day, it's a very human service that you're providing, and it sounds like your staff have really been very flexible and bent over backwards.
Incredibly resilient all the way through this, even to the point of doing shopping for patients. They fancy this and they fancy that, and quite a lot of the staff will go out and they will go to the supermarket and they'll buy it. Now that's an extra role. They're happy to do it, may I add. But I mean, how wonderful is that? It's just, I'm so proud to work within this service. Honestly,
it's at a time like this, people just rise. The good people just rise to the surface, don't they?
And at the beginning of this, the fear that we all had. Because none of us knew what to expect. None of us have ever done anything like this. There's been lots and lots of tears, but they have come through and just incredible and just surpassed all expectations. I already had high expectations of them, but they've just surpassed that time.
They're a special lot.
They're incredible.
It's a very shared experience, isn't it, COVID? Because it's affected everybody in some way. We've all got our fears, or elderly parents, or children.
I think, but within the news, there was all this fear that everybody's chemotherapy is going to stop, everyone's cancer are going to be at really high risk, everyone's going to be dying. But actually, patient who's come through the doors or on the phone, all of our staff have had to deal with each patient's own anxieties and fears, and they've dealt with it incredibly well. There are some who don't want their treatment stopped, there are some who don't want to come into hospital at all, and we've had to try and come with a plan with each patient and try and alleviate the different fears and worries that each patient and relatives have, and keep them safe and make sure that their treatment and their cancer is being managed appropriately.
I must say, when I visited Brabourne, it did feel incredibly calm, quite normal actually.
It's very
impressive.
Yeah, it's not. We try not to have a hospital environment, so it's not so clinical. It's a bit like a home away from home. That's how we like to think about it. But obviously, sometimes we are rushing around and delivering medicines and things like that. But we try to. It's very friendly. It's very homely. It's just wonderful. So I can't say.
What I had wanted to just hear about is because what makes your unit special is the research.
Yes.
So you are a big research unit in the country. What has happened to your research during this time?
So as the majority of the trials across the country, a lot of them have been put on hold. We have had a couple which have still been open, and we have been recruiting a couple of patients to these trials, and we've had to look at each one individually and weigh up what benefits will each trial potentially provide for our patients during this time, and if there are some which perhaps the chemotherapy regimes may be too intense, require too many visits to the hospital, then we've kind of put those on hold and we'll wait till we can reopen. And a lot of trials nationally have just been closed, so we've only had, I think, a couple that we've actually been able to enrol over this time, which has been difficult. But this work still goes on for managing and monitoring those patients who are already in trials and making sure that we're managing them appropriately and we're getting the right data for all the research despite COVID. So it's
interesting when those hibernated trials wake up again.
I know, particularly because I think we're also expecting an influx of new referrals to come through from the GPs. We have still been getting referrals, but the numbers that have been coming through have been quite low. So I suspect when COVID does and normal service does start to resume, we're going to be expecting a big influx, and that will provide a lot of work and potential stress. But we know that the role of research for our patients is incredible, because we get potential access to new drugs that are coming through, which we wouldn't have for our patients otherwise. And some of the trials have been involved and have been practice changing and provide significant benefits for our patients and the way that we will future manage these patients. So,
No, I'm sure the patients appreciate they're in a research active organisation, and that's really helpful for them. So just coming to end, what are your sort of lasting memories of the last 4 months of COVID? What will kind of stay with you?
I think the thing that I really miss actually, that I've really missed over the last 4 months, is I've not been able to touch patients. I've not been able to see them face to face. And there's a whole cohort of patients that have come through that are new patients, and I know their names and I know their voices, but I've never met them and they've never met me. And that's a real shame, but it's a challenge that we'll have to deal with going forward.
Thanks, Stephanie. What about you, Jess?
I think for me what I have found most difficult is providing end-of-life care without touch. I would like to be able to just hold a patient's hand without gloves on and to shake a patient's relative's hand, to give a patient a cuddle when they need it. You know, they do need it, and that's been really tough. But I think, like I said, this team have been so resilient. I think they should be so proud of how they've coped through this. It's shown different characters and different sides to us that we didn't know existed. So it's been
good. What about you, Moya?
I mean, I have to echo what Steph and Jess have said. We are a hands-on team. We do have a lot of close contact with our patients. We get to know them over a long period of time, and not having perhaps that close engagement right at the beginning when you're telling people about their new diagnoses and being there directly, like to talk about the chemotherapy complexities and what may or may not happen. It's been quite challenging. We'll be looking forward to the day when normal service can resume, but I think our team has been very strong. We've adapted very quickly. We've come together very closely and have worked together really well to make sure that our patients are still getting a good quality of service throughout this, and being able to provide chemotherapy to the vast majority of our patients without significant changes, and hopefully, touch wood, not impacting too much on their long-term outcomes. I think we should be proud of ourselves.
Absolutely. I'm proud of you. You've done a fantastic job. And yes, we all hope that it'll come to an end soon, but I think we'll end up refining what we're doing at the moment. So thank you very much for your time. I appreciate that very much.
Thank you.